entre la chirurgie thoracique et la chirurgie cardiaque.
Cardiaque, très bien.
Et lorsque j'ai terminé ma formation en thoracique, lui, il est venu juste après. Et moi, je suis allé en cardiaque. Mais c'est surtout avec professeur Gilbert Massard.
Massa, exactement, Massa. Moi, j'ai vu Falcos, je connais Falcos en Hollande, à Amsterdam. On a fait beaucoup de travail ensemble. Je connais les gens de Rouen, surtout. J'ai fait beaucoup de stages à Rouen avec Jean-Marc Bast.
Ah oui, il est excellent, Jean-Marc.
Il est excellent surtout sur le robot, actuellement sur le robot.
Il est excellent dans tout, en fait.
Dans tout, oui, le robot, oui. Il est magnifique en type, il est très gentil, très compétent. C'est une bonne personne. Moi, je suis à Alger, la capitale. Je travaille là, ensemble. Enchanté, très heureux de vous connaître.
Moi aussi. Moi aussi.
We wait maybe 2 or 3 more minutes. Professor Ahmed Mustafa just told me he finished his surgery and he will join as soon as possible. Maybe we just wait a couple minutes more and then we can start.
Maybe for the next time, we should send you our mini CV so that the moderator would introduce us.
I have an agenda, Dr. Mansa.
Yeah.
And with the brief introduction of you, each speaker,
okay.
I'll try to make them all correct. If it's not correct, you can tell me.
Yeah.
I just see that we will be live very soon. As Professor Ahmed Mustafa is the last speaker, maybe we can just start and then later he will join. What do you think about this?
Sure.
Maybe just a few minutes more, a few moments more. Okay. So, hello everyone, my name is Tariq and I'm part of the International Sales Department at Easy Search Medical. It's our greatest pleasure to welcome you today to our first thoracic webinar of our surgical webinar series. Now we are at the end of the year and if we look back, we can see that we did around 15 webinars and most of them have been colorectal or in the bariatric field. And we got a lot of requests to do more in the thoracic field. So today is our greatest pleasure to welcome you to our thoracic webinar, and the topic for today will be opportunities and challenges for thoracic surgery in recent years. I would like to introduce first of all our speakers and the moderator for the session. We have Dr. Cheng Xianhua from the Shanghai Chest Hospital here in China. Then we have Dr. Ziad Mansour from Lebanon, Dr. Karim Mansouri from Algeria, and Dr. Ahmed Mustafa from Egypt. These three will be our speakers for today. I would like to thank you all for taking your time. I know everybody is right now doing something. Professor Ziad Mansour is right now in a congress in France. Dr. Ahmed Mustafa is right now in a surgery. He will join us very soon. So thank you all for taking your time. And it's a pleasure to have such an international group of leading surgeons with us here today. And considering your rich experience and expertise, I am more than confident to say that this webinar will be a very successful one. It's a pleasure for us as Easy Search Medical to provide such a platform where leading surgeons can come together and discuss the most recent and most important topics in the thoracic field. And I would also like to thank everyone who's taking his time all over the world to join us and to follow this webinar series. It's a pleasure to welcome everyone who has been already with us, maybe in some other webinars, or who's new to this webinar series. And now I would like to give the word to our moderator, Dr. Cheng Xianhua.
Thank you, Mr. Corey. It's my great pleasure to be the moderator of this great webinar hosted by the ESOC Thoracic Academic Webinar. And it's my great honor to introduce 3 speakers of today's meeting. They are Dr. Ziad Manzoor. He is the head of the cardiothoracic surgery program at the Lebanon University, and is also the faculty of science. He's going to give the presentation, the first presentation, the history of minimally invasive thoracic surgery in Lebanon. And also Dr. Karim Mazkouri. He's from the Department of Thoracic, Cardiovascular, and Organ Transplantation Surgery from Algeria. He's going to give our second presentation. And also Dr. Ahmed Mostafa. He is the professor of thoracic surgery at Faculty of Medicine and Shamar University Hospital, cardiothoracic surgery from Egypt. And he's going to give the presentation about how to start a lung transplantation program in Egypt. Is it possible? I think all these 3 topics are very interesting, and they are all actually they tell us different story from different parts of the world. So I'm very interested to listen to these talks. So first, let's welcome our first speaker, Dr. Ziad Manzoor. He's going to give us the presentation about history of minimally invasive thoracic surgery in Lebanon. It's your turn, Mr. Manzoor. Thank you.
Thank you, Dr. Chan. I will start by sharing my screen. Do you see well my screen now?
Yes.
Okay. Do you see well the slides?
Very clear.
Great.
Yes.
Okay. First of all, I would like to thank the moderator and our co-speakers, and especially the Easy Search team who planned this webinar. And I will be talking about the history of minimally invasive thoracic surgery in Lebanon. The plan of my presentation will be talking briefly about the historical thoracotomies. Then we'll talk how we switched to triportal VATS, and then to the VATS mini thoracotomies, and we end by the single incision VATS in Lebanon. So during my training in France, it was between 2003 and 2011. I used to do major lung resections, but usually almost exclusively by a muscle-sparing anterolateral thoracotomy of about 25 centimeters. It's usually in the 4th intercostal space, and we almost exclusively did posterior lateral approaches only for pancreas tumors, some chest wall resections, and sometimes for the latissimus dorsi flaps in the case of a bronchopleural fistula. And as you all know, we have the rib cage, and we pass in between the ribs without cutting them. The advantage of the anterolateral approach is that we spread the muscle fibers of the serratus anterior muscle without cutting them, and if needed, we push back the latissimus dorsi muscle, and then we pass through the 4th intercostal space to access the pleura. In terms of positioning, we bend the patient posteriorly to get an anterolateral approach. Otherwise, we have to bend him anteriorly to get the posterior lateral approach. As you can see here, in a posterior lateral approach, we have to cut the latissimus dorsi muscle, and it might cause a major pain in the post-operative period, and it can be accompanied with more complications due to lack of good respiratory efforts after the surgery. We also have to use multiple retractors in major thoracotomies, and this will induce a major crash in the intercostal nerve that will cause referred pain below the nipple. This is one of the major openings I have done for a huge intrapleural tumor. This is the anterolateral approach. As you can see, we spread the serratus anterior muscle. We have the latissimus dorsi muscle, which is being dissected without being cut. And we can also use the sternal retractor to have this wide opening to resect. It was a huge nerve sheath tumor that we had to resect, and this is becoming exceptional nowadays. Using the classical rib retractor, we have a perpendicular blade that will come and will crush the intercostal nerve. And after the surgery, we'll have a referred pain below the nipple. And this is very painful and annoying for the patient for a long period of time after the surgery. Then we switched to the port thoracic thoracoscopic surgery at the beginning of our experience in France, and it was mainly for pleural surgery and for wedge resections. Then I went back to Lebanon in 2012, and I faced the lack of equipment, and this is one of my first thoracoscopic procedures. And in fact, I had almost no instrument. I used the laparoscopic instruments with very wide trocars of about 15 millimeters. I had to do about 2 centimeter incisions for each port. And yeah, with the 3 reports, it was not sufficient. I had to create a fourth 1 centimeter incision to introduce instruments. And despite all of that, this patient, we spared him a major thoracotomy. And this is the end result 3 weeks after. Aesthetically, is not that bad. And for the beginning of our experience, it was a relatively good result. Then I started to have better equipment, and this is a wedge resection I performed in 2013. As you can see, the length of the incision has diminished, and we used one of the ports to introduce a plastic chest tube. And this is the end result 10 days after the surgery, which is still accepted. And then we went with thoracoports, and we had small trocars so that the incisions are becoming shorter. And we usually use a single chest tube for thoracoscopies. It is a plastic one, and I'm still annoyed about this stay suture that aesthetically is not beautiful to see. And then I switched to the dual port thoracoscopy. This is the case of a young patient who had a car accident with a major hemothorax. So we had to operate him during the night, and in fact, we only used 2 1 centimeter incisions to introduce our camera and our instruments to take out the clot. And this is the end result with always the stay suture that annoys me a lot. And then I switched to pleural carcinosis surgeries with exclusively 2 small incisions of about 1 centimeters, where we can introduce the camera and the equipment to drain the effusion, to do our pleural biopsies, and then to put talc before closing the patient and introducing a plastic chest tube that remains painful for the patient with a stay suture here. Concerning empyemas with thick pus, I started with small thoracotomies, video assisted with a small incision below the major incision of about 5 centimeters to remove the pus, especially in the costodiaphragmatic angle where we have thick pus, and we usually use the camera to see them, and we introduce our equipment to the thoracotomy to remove all of this. And this is the end result 10 days after the surgery. Then I was able to do the same thing with a single incision. It was by the end of 2013. It was about 2 centimeter incision. We introduced the camera and all of this. At the time, I did not have the wound protector. And this was the end result after the removal of the single chest tube. Then I started the video-assisted wedge resections with, in fact, a mini thoracotomy with a small incision to introduce the camera. This was an 83-year-old patient who had a 4 centimeter tumor. It was lung cancer, but we were not able to do a major lung resection because of the lack of functional reserves in her lung capacities. So this is why we opted for a wedge resection. And we did all of this with a small 4 centimeter incision and a small incision to introduce the video. And then in around 2017, I had the silicone chest tubes, the 15 French Blake chest tubes. So I was able to remove the stay suture. I'm not using it anymore. And in fact, this is a patient who had recurrent pneumothorax, and we operate him for a pleurectomy with pleurodesis with 3 1 centimeter ports. And we introduced the 15 French Blakes through these incisions, and they go out from the skin. They are being introduced in the intercostal spaces without creating a new passage into a new intercostal space. And this is the end result 20 days after the surgery. For major lung resections, such as lobectomies and pneumonectomies, I had to start with the 20 centimeters thoracotomies, as I was trained in France. And at that time, I did not have the endo-GIAs. And as you can see, we have a very ugly aesthetic result by the end of the procedure. And I used to insert two plastic chest tubes in the 6th intercostal space that usually created another referred pain below the nipple. And this was annoying for the patient and for myself also. Then with the same technique, I reduced the incision from 20 to 15 centimeters with always 2 plastic chest tubes. And the aesthetic end result is not that good. I was not satisfied. And patients always were complaining from a referred pain below the nipple. And then I got the endo-GIA staplers, and with this I reduced the incision for around 10 centimeters with always 2 plastic chest tubes. And with time, with the same endo-GIAs, I was able to reduce the incision for about 7 centimeters, but I was still not satisfied with the aesthetic end result. So I switched to a single chest tube in selected cases. As you can see, this is around 7 centimeters of length. This is a very small patient and a single chest tube. And this is our end result 10 days after the surgery. Then I got in 2014 the mini retractor with a blade that is about 3 centimeters of length. And with this, I was able to do exactly the same surgery with a 6 centimeter incision. And I was still introducing the dual plastic chest tubes. The end result is better, but I was still not satisfied. So I continued on reducing the incision. This is a lobectomy patient with around 5.5 centimeter length of incision. And this is what we had 3 weeks after the surgery, and I was still annoyed by this stay suture. And then in 2017, I had the Blake drains, and I introduced them through the same intercostal space with a subcutaneous pathway before going out from the skin. And this is how we get a nice, relatively nice aesthetic result, especially in women who will wear bra, and this incision will be hidden by their brow. Then, starting 2018, we had the EasySurge endo-GIAs, and the major improvement was the angulation of about 60 degrees. And I had the opportunity to have the 3 major lengths, the 30 millimeter staplers, the 45 and the 60 millimeters. And this gave me more maneuverability to inside the pleura so that I can reduce further the incisions. This is, for example, wedge resection. I did it with a single incision, and by 2019, I had the wound retractor that gives me more space during the surgery. And this is what we had by the end of the procedure, a 4 centimeter incision with a single 15 French chest tube that was introduced at the same intercostal space and having a pathway in the subcutaneous tissue before going up from the skin. So in fact, we reduced the pain that was referred from the plastic chest tubes, and we drastically reduced the pain coming from the referred pain from the 4th intercostal space. Then I had this nerve injury sparing retractor in 2019, and the major advantage is that the blades can be bent. And by using this, we have the intercostal nerve that is hidden in this groove. And in fact, it is no longer crossed by the retractor. And this is how I was able to do major resections. And in fact, at the same time, I started a new thoracic surgery program in Beirut. And fortunately, the hospital administration accepted to buy the minimally invasive equipment. And this is how we became exclusively minimally invasive, even in very obese patients such as this one. She had maybe 7 centimeters of thickness in the subcutaneous tissue. And we operated her with this mini retractor. And as you can see, it is bent in here, and the intercostal nerve is hidden in this groove. And sometimes I don't even use the video scope. I only use this headlamp to be able to see the whole of the pleural cavity. And we did a lobectomy with a 6 centimeter incision, and we introduced 2 15 French chest tubes through the same intercostal space. And then this is a male patient operated with the same technique. This is a 6 centimeter incision for his lobectomy, and these are the exit sites of the 15 French Blake chest tubes. And he was complaining of almost no referred pain from the thoracotomy. A year later, we have difficulties to see the incision by itself, and the end result is, at least aesthetically, is satisfying. Then, with the help of our local distributor, Mr. Rogeron, who is very enthusiastic for thoracic surgery, I had the opportunity to visit China, and we started our visit in Nanjing Hospital, where they were kind enough to introduce us the 3-port segmentectomy, the thoracoscopic segmentectomies, and they even offered us this very nice right angle dissector, which I still use until today. And then they trained us for the triple port segmentectomies, and it was a very nice experience. Then we spent some time in the Shanghai Chest Hospital, where we were introduced to the dual incision major lung resections with very small two ports, and using the wound protector. And I was amazed by the techniques they have in Shanghai Chest Hospital. I'm really amazed. Until today, I still tell people how skillful they are. And in fact, they use the EasySurge staplers. And I had also the opportunity to visit the EasySurge headquarters, where I was introduced to the richness of their staplers and all the lengths they have and the thicknesses. And I was shown how the staplers are being made. And this is how I got enriched with the techniques, so that I can apply them in my clinical practice. And with this visit, I could improve the practices in Lebanon. And this is the first operation after my Chinese visit. And this was a cystic lung, and we had to do a major wedge resection. So with only 2 centimeter incision, we put the wound retractor, and we had a 5 centimeter incision to introduce the camera. And this is the end result. We used the lower incision to pass the 15 French Blake chest tube. And the patient had this end result just after the surgery. This is the day 1. And in fact, we don't have a stay suture. We only close this incision using Steri-strips. And this is how I eliminated the stay suture that annoyed me for years. And this is the end result 10 days after the surgery, and the patient is doing well without no referred pain at all. And then I switched all my practice to uniportal VATS, and this was a mediastinal tumor resection at the station 4R. It took me some time at first, but we were able to do it. And then I switched to uniportal VATS lobectomies. As you can see here, with the same incision, we are introducing the camera, the equipment, and we, as you can see, we can see well the hilum. This was dissecting the pulmonary vein. And this is the first uniportal VATS lobectomy in Lebanon with a 5-centimeter incision with our famous two 15 French blade tubes. And then we switch to almost exclusive uniportal VATS major resections. As you can see, we can introduce the EasySurge endostaplers with a rotation of around 60 degrees. We have the 5 millimeters camera and the same incision, and we have the equipment to perform our surgery. And we are becoming more and more skillful with time. And you can see how we can our view is very clear, and you can see our endo-GIA doing the wedge resection here, and then we are able from time to time to do a 2-centimeter incision for a major lung resection with our famous 15 French chest tube that is introduced in the same intercostal space. What is the future? I believe that the future is for research and development. I had the opportunity to discuss with the R&D team in EasySurge. We shared ideas, and we are still improving the equipment. And hopefully, I will be visiting the new EasySurge headquarters in Shanghai, maybe very soon after the COVID era. Thank you very much for your attention.
Thank you very much, Dr. Manzoor. I'm very impressed by your presentation about how your surgery is improved, is evolved since I think it's 2003. I can see very clearly like your technique has improved a lot from like a very large incision to uniportal VATS.
Thank you.
Yeah. How many surgeries you do? Say, what's the percentage of uniportal approach for your total cases?
In fact, for it's almost exclusive uniportal VATS, almost exclusively. Nowadays, for example, for a neuroplastic pleural effusion, I usually use the two 1-centimeter incisions. I think we have better maneuverability in the pleural because with a single incision, we don't see well with the 30 degrees camera. And to do our pleural biopsies, it's a little bit of a hassle. So I stayed on the two 1-centimeter incisions for pleural surgery. Otherwise, a single 2-centimeter incision to do the pleuroscopy and all of that. For major lung resections, in fact, when we reduce the length of the incision, we have sometimes healing problems in the incision site. So in fact, I enlarge to 3 centimeters, and usually it's sufficient, especially when we use the wound retractor, the wound protector. It gives us a wider operative field, and patients are not complaining anymore from the referred pain. And aesthetically, I'm very satisfied with the results. The other day we had a thymectomy. I did with a 2-centimeter incision, but I did a second 5-millimeter incision for the camera, exclusively for the camera. And this 5-millimeter incision was not seen 10 days after the surgery. In fact, we don't put any suture on it. It's only with Steri-strips. We have excellent results, and patients are extremely happy.
That's good. That's very good, both for you and your patients.
And in fact, I have to thank the Chinese health system. Really, it was a 3-day stay there. but I learned a lot of them, and we see techniques we don't see in Europe and in North America, really. I would like to visit Shanghai soon, whenever the COVID era has stopped and I have controlled the epidemic. I'm eager to go there again and again and again.
And welcome.
Thank you.
I think we are now. I think our techniques and stuff is also evolving. We're trying to. I think we use uniportal approach to treat most of the lung resection, including lobectomy, including the sleeve resections. Yes, I think you can. It's enough with the development of the instruments. We still have a lot of potential in future. Good. Yes. So thank you very much. So let's welcome our next. Speaker, Dr. Maskouri Karim from Algeria. I don't know whether I pronounce your name correctly.
Yes, it's correct.
Sorry. Yeah. So he's going to give us a presentation about how to establish the minimally invasive thoracic surgery program in a developing country.
Yes,
it's your turn.
Thank you. Hello, everybody. Mr. Moderator, dear colleague, I am very happy today to participate with you in this webinar. And before beginning, I would like to thank Tara for the perfect organization of this webinar. I am going to present you today my modest presentation. I'm going to present you the establishment of a minimally invasive thoracic surgery program in emerging country. I am Professor Karim Maskouri. I have been thoracic surgeon for more than 15 years in the thoracic and cardiovascular surgery and organ transplantation department of the CSU Mustafa Algeria, the largest thoracic surgery center in the country. The largest thoracic surgery service in the country with a significant volume of operative activity, average 1,100 patients operated every year before the pandemic, including 80% of pure thoracic surgery and 20% of vascular surgery, abdominal aortic, carotid, and lower limbs. The thoracic surgery activity practice, surgery of pedicular cancer, mediastinum surgery, pleural surgery, pulmonary edentity surgery, infectious pathology, water diving, stenosis of the trachea, diaphragm surgery, and associated with the regular emergency activity. 95% of thoracic procedures are done in the open, and only under 5% for the moment by video surgery. In thoracic surgery, minimally invasive approach for major pulmonary resection and mediastinal tumors have taken longer time to establish themselves. However, in recent years, minimally invasive surgery has been commonly performed in certain indications, early stage cancer, thymectomy, for myasthenia gravis, fragile patients. The benefits of this surgery are basically short-term benefits, a reduction in postoperative pain, a shortened hospital stay, earlier resumption of physical activity, better access to chemotherapy if needed, and a lower overall cost compared to thoracotomy. However, given the diversity of surgical indication, minimally invasive thoracic surgery involves variable modality and large vessel dissection, always carries a real operative risk. Learning this minimally invasive technique is therefore difficult. This new technology is a priori complex and raises questions about the training required and the initial result. Our objective and goals. After reviewing the literature, all the publications show the advantage of video-assisted thoracic surgery. We report today the implementation of such a procedure in one of the Algerian university centers and the first result in a unit with a large volume of activity. Throughout this presentation, I will expose the experience, the modest experience of a high activity service that begins in VATS compared to thoracotomy. The aim of this retrospective study was to report the result of our initial experience with a minimally invasive surgery. Our patient and methods, number of patients per year is 1,100 patients, on an average 85% of which are poor thoracic surgery, and we have 500 resection, major resection per year, and half for the leg cancer. This figure has helped in 2020 and 2021 in relation to the COVID-19 pandemic. From October 2018 to November 2021, we have practiced 176 patients were operated under VATS first line. The distribution by sex, we operate 134, 76% men, and only one children. Distribution by age between 14 and 60 years, we practice 43%. And the different pathologies, we practice a lot of 75 pneumothorax, mediastinal mass, lung cancer, pleural effusion, pleurisy, emphysema bubble, pericardial effusion, cyst edatic of the lung, interstitial syndrome, stranger body, bronchial dilatation, and pleural thickening, pulmonary sequestration. All our patients have benefited from general anesthesia, selected intubation, and anti-bioprophylaxis. The ways we practice a lot of 155 3 ports and only one monoporter. Extubation for all patients on table and 1 to 2 drains at the end of the operations. We have 3 ports, the intervention and the CKC post-operative. The gester practice, we practice 43 atypical resection and pleurectomy, 28 pleurectomy, lobectomy only 15, and bulectomy, pleurectomy, decortication, and another pathologies like exercises, mediastinal mass exercises, pleural biopsies, mediastinal mass biopsies, and another thymectomy, pneumonectomy, exercise of a hilar mass, segmentectomy, and targage. The duration of intervention, between 2 and 3 hours, 92 case. And for the stranger body extraction, 45 minutes, and greater than 3 hours for decortication, lung resection, thymectomy, and segmentectomy. Among 166 patients, conversion, very important, 52 patient conversions. Because the technical difficulty, 29 cases, bleeding and the lung not excluded, and cardiocirculatory arrest. The mortality, we have 9 mortality, 1 mortality intraoperative by bleeding and 8 post-operative. The draining, all the patients, 2 to 3 days, 52 patients, and 3 and 4 days, 82 patients, more than 4%, 37 patients. Duration of stay, 3 days, and the median is 16 days. Discussion. The objective of this work was to analyze the first result of video-assisted thoracic surgery in a surgical center of moderate size with a poorly specialist paramedical team and medical team in training. Prior experience and mastery of major open air excision was an asset. For the future, development of the VATS, initially for sample lesion, we start with the sample lesion, thoracoscopy, better vision, better exploration, better control of the cavity, drains, and vision control, material adapted to the VATS, long curved players, ultrasonic equipment, latest generation stapler, HD camera, and the future complex lesion. Our theory, we have male predominance, young subject, and the pneumothorax is the pathology with the importance case. In the latter, the trend is currently oncology. The literature at the beginning of the experience, male predominance and bronchopulmonary cancer. We have a lot of conversion, 30% conversion is very important with comparison of the other series. The last series have average conversion rates of around 10%, varying between 1% and 20%. The reported causes of conversion are bleeding and anatomical variant of the pulmonary artery, or more often, they need to expand tumor resection. Despite these failures, minimally invasive thoracic surgery has many advantages over conventional surgical technique. Mortality, we have 9 mortality. The literature mortality is very rare because selected patient, experience of surgical teams, seniority of the VATS, and the conversion at the right time. The average GNI time, we have 3 days minimal and maximum 22 days, average 7 days. What is found in the record is under the thoracotomy. Morbidity, we have 23%, 25 cases with morbidity, with sepsis of the drain hole, sepsis of the wall, detachment and persistent bubbling, parietal hematoma, and subcutaneous hematoma, 1 case. The initial results of our series are encouraging in terms of operative results. Compared to the different published series, our series is quite varied in terms of indication, but few surgical procedure resections, with operating time and longer room occupancy. Many conversions to conventional thoracic surgery were necessary. This is probably linked to the still limited number of cases and to the learning curve. I am going to present to you 1 case. It's a man, 61 years old, with a mediastinal tumor, exercises of the mass by VATS. There is a tumor, right side, mediastinal right, the CT scan, and the 3 ports by VATS. This is a video, a short video. This exercise of mass mediastinal by 3 ports. It's not very. This is a tumor, and it's the post-operative cicatrice. For the conclusion, VATS is safe and beneficial method compared to thoracotomy. Mono or multiportal, hardware development and availability, hardware dependent. Emerging country, it's very difficult to follow, actually, relatively long learning. Our initial experience with VATS lobectomies confirms the result already reported for this technique as a first-line treatment for early stages. These general benefits tend to broaden the indication of this technique for more advanced pathologies and stage. This early experience suggests that video-assisted thoracic surgery is a safe and effective technique for the management of various pathologies, with low morbidity and without significant learning curve, even in a center with moderate volume of activity. This technology should accompany the development of thoracic surgery. The importance of learning how to video-assisted surgery should be emphasized in order to optimize procedure. The minimally invasive thoracic surgery can be performed in a center with a moderate volume of activity with encouraging initial results. Initial training is necessary and can be optimized. The profitability of this procedure can only be achieved if the programs are quickly operational and our prospects for minimally invasive thoracic surgery are real. And before the end, I would like to thank all the whole team of thoracic surgery of the CHU Mustafa Algiers, and thank you for your attention and your patience.
Thank you, Dr. Mascori. Very nice presentation. Thank you very much. We all have experience of studying, learning a new technique. I think at the beginning of each new technique, it always takes time. You have to practice. You have to accumulate different experience in various cases. But I think once you have get to the plateau of the learning curve, and then once you have more case to practice, and you're gonna get more confidence, and then you're gonna more and more practice more and more VETS surgery. I think I have very short question for you, because in China we have some kind of like video banks, You can upload your videos, your surgical videos, to this kind of websites, and then you can also record your own videos. Like we have a USB.
Yes.
Like we can record every surgeries, and then we compare our own surgeries with this online video resources. I don't know whether you have this kind of resources in Algeria. If not, actually, I think you can browse the Chinese one. I think there are like videos. You can. Because I learned a lot from the videos. I recall at the beginning of my VETS practice, I record every single surgery, my own surgery, and then I practice and then I compare my video with the other videos. And I feel that's given me a lot of lessons. I learned a lot from this kind of comparing. And actually, we are writing a paper to introduce this kind of method to the other. We actually submit this paper to a thoracic journal recently. I think it's very helpful. Using this kind of technique, we have shortened our learning curve from over 100 cases to like 30 to 40 cases.
40 cases, yes.
Yeah, maybe. Yeah, maybe.
We have a large activity. We have a lot of lung cancer by year. We have 400 cancer by year.
Yeah, great.
And we practice only on open thoracic. Yes, open thoracic.
Yes. Very, very nice. Is any question from the other speakers? I think we can also discuss.
Dr. Chen, how are you? How are you?
Nice to meet you. How are you?
How are you?
Dr.
Well, thank you very much for this webinar. And I'm just commenting on your kind comment. Do you have these video libraries? Is it for? Can we access this library online, or will it be difficult?
I think in China we. We have we do have this kind of a website. I should be able to give you the link up this webinar if the if EasySurge can provide us, or maybe I can send email to you if you leave your emails there.
Excellent.
Or other speakers can leave emails. I can send the websites to you. And also we have the WeChat. This kind of a social chatting software in China. We using this WeChat app. We can also browse very large video resources through this app.
Okay.
Maybe if you download this WeChat, we can
be very kind
add each other. I can send you the resources via WeChat as well.
Very good.
I think we have like hundreds of thousands of different kinds of like thoracic surgery videos online. Yeah, no problem.
That's very kind.
Good. Dr. Mustafa, I think there's something, I think the internet, to do with the internet.
Yes, that's great.
Okay. I think there's something wrong with my internet. I can't.
Okay, do you hear me now? You hear me?
Okay, I can hear you now. Yeah, okay, yes.
You hear me all?
Yes.
Hello?
Now it's good.
Yeah, okay. I can see you clearly. Okay.
That's good. Okay, so let's welcome our next speaker, Dr. Ahmed Mustafa from Egypt. He's going to give us a little bit different topic. He's going to introduce how to start a lung transplantation program in Egypt. Let's welcome Dr. Mustafa. Thank you very much for your presentation.
Hello?
Hello, Dr. Mustafa, can you share your screen? Hello?
Hello?
Can you hear
Yes.
me?
Yes. It is carried on. You see it?
I think your screen is freezed.
I can.
I think your screen is freezed. Can you
This
share the
is
screen?
now?
We can hear you, but we can't see your slides. Oh, okay. It's come back now.
Really? Okay.
Okay, it's fine now. I think. Yes.
Okay.
Good.
Is it
Yes, we're back.
Okay.
Good.
Okay. Well, thank you again for the opportunity. With Easy Surge, and actually this is Easy Surge, and I'm very glad to see this product and to deal with the company that has introduced me to some great guys like you. Well, I'm tackling another topic, which is the living donor lung transplant in Egypt. Is it possible? This was where I've been trained in France in HEGP, Paris. We were trained in a very experienced department, and one of our experiences there was the cadaver transplantation. Now, when I moved back to my homeland, I've joined the Ain Shams University Hospitals. You still hear me, I think, huh? Hello? Hello? Hello?
Yes, Dr. Ahmad, we can see you. We can hear you very clearly.
Okay. You're great. For our patients, we have 4 beds. We're upgrading existing hospitals, adding new facilities, adding new ones, adding new subspecialties. We're modernizing our current services, and our administrative team is having a lot of reform. And living transplantation, liver transplantation, living donor living transplantation program They started in Kyoto University in 20 years ago, and now the service is of the liver transplant is done in many centers here, like 6 or 7, with built anesthesia and ICU teams in each center, caring for more than 1,500 patients in the last 50 years. The last 20 years, I mean. For our university, of course, main surgeon, all surgeons had their we have all the experience. We have an established preference to oncology, trauma, and we have very valuable experience in the device. Yes, told you operate like 102 cases, 50 hospitals, 60 vets, to open surgery with all kinds established. We established the low organ transplant and in each study is responsible. That's why that is on methods. So development and use the markers to deny the current cadaver don't have a more coverage lung. Actually, the living donor lung transplantation regular amount due to the prolonging time for count. Very encouraging that went out with bilateral living donor lung that provide better than conventional cadaver here in Kyoto. From two and the left to me and then the books. We have started to in Egypt, we kind of so matters use for several reasons. So properly frequency and competence and persistent reason from the government training on universities. The records are program COPD, collaborative relation referring in different regional meeting conferences, raising. We have put our general lines regarding the characteristic. Now we're not dealing with the extent like mechanical ECMO, very low BMIs, because we are just taking care cost benefit of this group. For the donors volume, of the geographic, it's important that vary. The AO component system with the long allocation score the very transplant because the living donor transplant is just a transplant match procedure. It's not done on emergency basis. We have a national lung transplant committee, regional transplant committee, and done limitations on official registry, also the donor team. Criteria, 15% of potential lungs are used. We have the donor criteria and we have send the donor team. Here we have many indicated lung transplant. Commonly used COPD is one anti-traps, emphysema, cystic fibrosis, bronchiectasis, primary pulmonary hypertension, phalangiomyomatosis, and of course, still great help. But this the case. Under 60 liability families
I guess there's something, there's some problem with the internet. Hello, Dr. Ahmed. I think he's offline. Hello, Dr. Karim. Can you hear me? Hi, Dr. Karim, can you hear me? I think we are a little bit ahead of time. Yeah. So maybe, hi, Dr. Dr. Mostafa. Are you back now? I can see your name now.
You hear me? You hear me now?
Yes.
I'm sorry.
Yes, we can hear you now.
Yeah.
It's fine. It's the internet, isn't it?
So again, for the size matching, you see the presentation right now?
We can't see.
Yes, now.
I can't see. I can't see the presentation. I can see the presentation. I can't see your face. I can only hear you, but I cannot see your face or the presentation.
Okay.
Can you open the camera, or you,
Yes,
you
sure.
can share this?
Sure.
Oh, we can see you now. We can see you now. Can
Okay.
you share the?
I'm sorry. Yes.
It's fine. It's fine. It's the internet. Okay. I think it's much better now.
Yes.
Good.
You see it now, I think.
Yes. I think the internet is getting much better now.
So we have been talking about the ideal donor, the ideal recipient, and now for the size match. The right lower lobe consists of 5 segments. The left lower lobe is consisting of 4 segments, and the Japanese has just given us a very nice solution for how to deal with the size mismatch in the living donor lung transplant. For the total forced vital capacity of the 2 grafts, it is measured by the forced vital capacity of the right donor multiplied by 5 segments over 19, plus measured forced vital capacity of the left donor multiplied by 4 segments over 19. So when the total forced vital capacity of the 2 grafts is 50% of the predicted, forced vital capacity of the recipient, calculated from his height and age and sex, size disparity can be accepted regardless of the recipient's diagnosis. So for the recipient selection, the transplant screening committee, its duty is the screening of the patient with end-stage pulmonary disease with disease-specific guidelines for the COPD, the cystic fibrosis, lung infections, interstitial pulmonary fibrosis. Early referral from transplant center for investigations and family education, a registry for eligibility for lung transplant, and a lung allocation score. We are doing the prioritization and transplant benefit. These are the labs intended to be done for the recipient. We stress on collaborating with the infectious disease department, gastroenterology, neurology, genitourinary, gynecology, nephrology, almost all departments. Sometimes we have to know exactly the real anatomy for the donor. There must be no surprises intraoperatively. So it's intended to do. We intend to do a 3D CT angiography for a left donor. This is a 3D CT angiography for a left donor, and the yellow dotted line here is the line of incision, incising the artery. This is done to confirm the anatomy of the pulmonary anatomy, the pulmonary arterial and venous anatomy. The volumetric size matching is used to evaluate oversized grafts. The 3D CT volumetry is performed both for the donor and the recipient. CT images are obtained using a multi-CT scanner during a single inspiratory pause at the end of the maximum inspiratory effort. A wide range of volume ratios between the donor lower lobe graft and the corresponding recipient's chest cavity. The upper threshold for the volume ratio appears to be about 200% based on a 3D CT size matching. And this is from the literature done by Professor Hiroshida Tei in Kyoto, whom I visited 2 times till now. So this is the anatomical size matching for a donor grafts and the recipient thorax using three-dimensional volumetric. Well, the upper one, the donor is 1.5 liter. The donor volume is 1.5 liter. The right donor, and the left donor is 1.15 liter, which is very sufficient. Now, this is from the anterior, the lateral view down. The diagram shows that the donor has 1.6 liters, its volume, and the other is 0.7, which is like 62% less, and still we can transplant this lobe. I will skip this and I'll go to a brief on the surgical technique. Performing bilateral living donor lung transplant requires a lot of manpower. Actually, 3 surgical teams opening 3 simultaneous OR. We communicate each other closely to identify appropriate timing for graft extraction to minimize graft ischemic time. We usually bring the recipient and the right-sided donor to the operating room at the same time, followed by the left-side donor 30 minutes later. So in our hospital, we are starting to do patient identification through registry, specialized clinics like the interstitial pulmonary fibrosis clinic, the cystic fibrosis clinic, pediatric respiratory unit, awareness or national referral. Then we do a multidisciplinary transplant clinic at our hospital, comprised of a surgeon, chest physician, and pediatric chest physician and a cardiologist. We then do our cardiological and lab investigations. Then we send the patients for a completely neutral ethical committee, psychiatry. We do him the radiology. Then the 2 donors and 1 recipient. We open 3 rooms simultaneously. We always now we will intend to use the central ECMO, abandoning completely the cardiopulmonary bypass. And the recipient will go to an isolation like 1 month. This is the average period to stay in the ICU, with a possible veno-venous ECMO post-operatively. Actually, in Japan, we haven't seen any patients needing the veno-venous ECMO post-operatively. We need at the ICU, we need an ECMO team with chest medicine, physical medicine, nutrition, radiology, labs, and pathology. While the 2 donors, a straightforward lobectomy is done for them with 1 hospital, with the 1-day ICU stay, and then both are transferred to the surgical ward. The donor stays 5 days, and the recipient may stay up to another 1 month, and then to be discharged and to follow up at the chest transplant clinic post-operatively. For the donor lobectomy, it's a straightforward lobectomy provided with some differences. When it's like here, when the recipient lumenectomy is nearly completed, we give an intravenous prostaglandin E1 and followed by methylprednisolone of 500 milligrams and then 5,000 units of heparin. Vascular clamps then are applied in the interlobar pulmonary artery, followed by the inferior pulmonary vein, intrapericardial on the left atrium. Then the pulmonary vein, pulmonary artery, and the bronchus are divided in this order. Vascular stumps are sutured with 5O polypropylene running sutures. The bronchus is closed with 4O PDS, interrupted sutures, and reinforced with pericardial fat. And at the back table, the graft is being flushed with preservative solution. The Perfadex, both anti-gradely and the grafts are ventilated with room air, gentle ventilation throughout the flush. The recipient here is undergoing a clamshell incision. Hilar dissection is performed before heparinization ECMO is used instead of conventional pulmonary bypass, which is preserved which is kept to some cases. The Japanese here, we intend also to put 2 draining cannulas, one in the right atrium and one in the femoral vein. The ascending aorta is then cannulated. The right pneumonectomy, we start with the right pneumonectomy. Then the right lower lobe graft is implanted with the following order: the bronchus, the pulmonary vein, and the pulmonary artery. For the pulmonary vein anastomosis, it's performed between the donor inferior pulmonary vein and the recipient upper pulmonary vein, leaving the de-airing procedure at the end of the reperfusion. The pulmonary artery is anastomosed end-to-end fashion with a 6-0 or 5-0 polypropylene suture. 500 milligram of methylprednisolone is given IV, and nitric oxide inhalation is started at 20 ppm. This is after the anastomosis of the pulmonary artery and the pulmonary veins. Then anti-reperfusion and de-airing is done, releasing the vascular clamp on the pulmonary artery, after which the right graft is reperfused and slowly ventilated with an ECMO flow gradually decreasing to 70% of the full flow. Then we do the same side, the other side, the left pneumonectomy and left graft implantation are conducted in the same manner. And after both lungs are reperfused and ventilated, ECMO is gradually weaned to a level of 10%. And if the blood gases the hemodynamics are satisfactory, the ECMO is completely weaned. I'll skip the ECMO strategy right now because we are running out of time. But I'd like to give a hint of the Avalon dual lumen single bicable cannulation technique, which allows the patient to be ambulated while maybe if he's put on an ECMO preoperatively or postoperatively to facilitate his ambulation. Here's a small algorithm. If we have I skip all this. I'll go to the post-operative management. The patient is kept intubated for more than 3 days to maintain the optimal expansion of the implanted lobar grafts. The pressure limited ventilation is used, and maximum ventilation pressure is kept less than 25 centimeter water. Fibroactive bronchoscopy is performed twice daily, and the triple duct therapy with cyclosporin, tacrolimus, and mycophenolate mofetil, the MMF, are used, while corticosteroids are used for the post-operative immunosuppression. Methylprednisolone 125 is administered intravenously during the first 3 days, and all immunosuppressants are given via the nasal tube inserted in the proximal jejunum at the end of the operation to protect the renal function. We intend to do concerning the primary graft dysfunction and the rejection. It's not common now to use the transbronchial lung biopsy for rejection monitoring. While acute rejection can be judged on only a clinical basis, careful monitoring of the chest X-ray daily and the clinical findings we can see on the patient. It's unique that the acute rejection is only seen as a unilateral pulmonary infiltrates because we have 2 donors right now. And this is a very nice comparison between the cadaveric and the living donor lung transplant. When acute rejection is suspected, a bolus of methylprednisolone 500 milligrams is administered, and the patient improves. If the patient improves after the first dose of methylprednisolone, 2 additional daily bolus doses are given. And this is from Professor Date literature. It gives the living donor lung transplant gives similar survival to cadaveric lung transplant, even for ill patients. Lastly, the strategies for size mismatch in the living donor, the undersized grafts. For large adults, 2 lower lobe grafts may be too small. Native upper lobe sparing living donor lung transplant is indicated with the total graft. I've talked about this in an earlier slide. When the total graft forced vital capacity is less than 60% of the recipient's predicted forced vital capacity, the surgical procedure of native upper lung transplant, sparing transplant, is similar to that of the standard living donor, except that the bronchus is most distally to the second carina, and the pulmonary vein to the lower pulmonary vein, and the pulmonary artery to the interlobar artery of the recipient. And the strategies for size mismatch in living donor lung transplant we also use in the right-left inverted living donor lung transplant. The donor right lower lobe is inverted and implanted into the recipient's left chest. Hello? I'm very sorry.
Hello?
Yes, I'm very sorry.
It's okay. It's okay. It's the internet. Yeah, we can hear you now.
Yes, I have just
Okay,
one
no
slide to
problem.
go. For the oversized graft, an adult lobe could be too big for a small child, and several compensatory techniques are done. A single lobe transplant, with or without contralateral pneumonectomy. We delay the chest closure with downside the graft using the staplers. Sometimes the middle lobe is just the one suitable for implantation. A single living donor lung transplant is also indicated when one living single, not bilateral, is only indicated when one living donor is found in the family and we can find another donor and the patient is very sick and we don't have except this just single living donor lung transplant to operate on. But the bilateral living donor lung transplant always provide a better outcome. I thank you, and I'm very sorry for the lengthy presentation. I'm very sorry for the internet connection. I'm in the hospital in the middle of many monitors, so maybe my connection is weak. And thank you for your attention.
Thank you, Dr. Mostafa. Very, very nice presentation. Thank you very much. I think even your talk is so interesting that even the internet cannot stop us. It's thousands of miles away from each other, but we can still get your point. It was very nice presentation. I've learned a lot. Because the donor issue is also a very challenging problem in China as well. We don't have that many donors.
Yes,
so
I know.
Our transplantation. Yes. I will tell your story to my colleagues because I'm not a transplant guy, but I'm going to tell your story to my colleagues, the transplantation team in Shanghai Chest Hospital. Maybe I'll try your methods. Very good solution. I think it's fantastic, amazing solution for the country like China and Egypt. We have like less donors. Yeah.
Hopefully,
okay. So this is the I think it's the Q&A session. I think all three speakers give very remarkable, excellent talks today, covering different topics, including how the evolution of minimally invasive program, how to set up a new minimally invasive program, and also how to set up a transplantation program in developing countries. I think the theme of our webinar today is the challenges and recent progress of thoracic surgery. I think the three topics are very just on the point. So for the discussion, I think it's a free talk. We have all three speakers online. Do you have anything like you want to talk about?
Well, I think it was a very good webinar with, I mean, the topics were diversified and we were sharing our mutual experiences in countries that are emerging. And in fact, I think with too much personal efforts, we can do the change in our countries. And we can prove that personal efforts can convince our administrative people that we have to change things, and we can advance the operative techniques and give better services to our population.
Okay, thank you, Dr. Mansour. Dr. Karim, you have any comments?
It's very good webinar, and the presentation of Mr. Dr. Mustafa and Dr. Mansour. It's very interesting, and I hope that I will perform a lot of cases for attending this level. And I would like to speak with Dr. Mustafa. I practice regularly kidney living transplantation. Not a lot of lung, but kidney only living kidney transplantation. And I hope the future for the lung transplantation, living or not. And it's very nice presentation, very good.
Thank you.
Thank you. Thank you.
Thank you. Dr. Mustafa?
Yes, I'm very glad to join you today, and I'm very glad actually to be introduced to Dr. Mansour and see how he tackled the VATS program, giving us his very nice talk and very nice pictures, progressing from a 25 centimeter to a 2 centimeter in it's very encouraging. I haven't heard of Dr. Mansour, but I'm very honored to know him now. And for Dr. Karim, it's to know you, such a big thoracic service. I hope you all the best. And at the end, I thank Dr. Chen from China allowing us and communicating with us and with his experience. And I'll I'll get you later, inshallah, to get the know-how for the video library. Yes.
Yes, thank you.
Thank you. Thank you. Thank you.
Thank you, Dr. Mustafa.
No problem.
Thanks a lot.
Thank you.
Thank you. Thank you very much for all the great talks today. And I'm personally very grateful for this opportunity to moderate and also to learn from all of you. It's a great experience to me as well. Thank you very much. Thank you again. Thank you for joining the virtual meeting today.
Thank you.
Thank you very much.
Thank you.
Oh, we hope. I really hope like we're gonna have like opportunity to meet each other face to face in real life. Okay.
Hopefully.
I wish you good luck.
Hopefully, yes.
All the best wishes.
Thank you.
All the best. Have a nice day.
Thank you. Okay.
Have a nice day.
Have a nice day.
Bye.
So
Nice day.
bye.
Bye-bye.
Bye.
Bye. Bye.
Bye-bye.
Bye.